Hi, I'm Rachel Winter, and our topic will be inflammatory bowel disease, IBD special issues for the boards. I have no disclosures. During this talk, we'll talk about extraintestinal manifestations of inflammatory bowel disease, including ocular, oral, hematologic, musculoskeletal, and dermatologic manifestations, also pregnancy and IBD, and preventive care guidelines for patients with inflammatory bowel disease. The prevalence of extraintestinal manifestations ranges from about 20 to 35% in patients with inflammatory bowel disease, and they may or may not parallel disease activity. Extraintestinal manifestations may present with the diagnosis of IBD, after the diagnosis of IBD, or may be the presenting symptom prior to a diagnosis of IBD. They may be associated with IBD, or there are also extraintestinal complications that are not necessarily manifestations that may be due to IBD disease activity or the disease itself. These may include nephrolithiasis, kidney stones, malabsorption, and nutritional deficiencies, among others. Patients may have one or more extraintestinal manifestations, and patients who have the presence of one extraintestinal manifestation are more likely to have a second or a third. This is a diagram depicting systemic complications of IBD. These include both extraintestinal manifestations and complications that occur with IBD. And as you can see here, there are many different organs and systems that are affected, including the eyes, the skin, the biliary system, bones or musculoskeletal, fertility, the renal system with nephrolithiasis, growth failure in children, and also increased risk of thrombus in the hematologic system. This is just a chart of different organ systems and the extraintestinal manifestations that may be involved. As you can see here, for example, in the musculoskeletal system, patients may have arthritis, ankylosing spondylitis, osteoporosis, osteopenia, or osteonecrosis. We will further talk about the eye, skin, and hematopoietic or coagulation manifestations. We are not going to cover the hepatobiliary manifestations in this talk. So the pathogenesis of extraintestinal manifestations is not well understood. There is thought to be a genetic predisposition. It is thought to be associated with HLA loci, and in Crohn's and ulcerative colitis, these loci are different and are listed here. To begin talking about ocular extraintestinal manifestations, these include episcleritis, scleritis, keratitis, uveitis, and orbital inflammation. Episcleritis is inflammation of the superficial conjunctiva. It is typically mild and self-limiting, though can be recurrent. Most cases are idiopathic, though up to 1/3 have underlying systemic conditions, and treatment can vary. It can include observation if it's a self-limiting course, artificial tears, topical steroid drops, topical NSAIDs, or oral NSAIDs. You must keep in mind that patients with inflammatory bowel disease are often advised not to take NSAIDs, so these should be used with caution, especially if they are going to be used for prolonged periods of time. Scleritis is inflammation of the deeper layer of the eye involving the white of the eye. It most commonly presents with complaints of pain and is most prevalent in patients who are aged 40 to 60. Treatment often includes oral NSAIDs, topical steroids, or oral steroids. Recurrent disease or disease that is severe enough to cause ocular damage may require the use of systemic immunomodulating therapy, and these therapies are often therapies that are similar to the treatment of inflammatory bowel disease and are listed here, including methotrexate, azathioprine, cyclosporin, mycophenolate mofetil, and anti-TNF medications. Keratitis is inflammation of the cornea. Treatment involves topical lubricant eye drops, topical steroids, or topical NSAIDs. And uveitis is inflammation of the interior of the eye, which can include either iritis, pars plantitis, retinal vasculitis, retinitis, or choroiditis. The disease tends to parallel the intestinal activity, but does not always. Patients often will complain of pain, redness, or photophobia, and the treatment varies by the area that's involved. Chronic uveitis or frequent recurrence of uveitis may necessitate systemic immunomodulating therapy. Alternative options include intraocular steroid or dexamethasone implants, and complications of uveitis may include cataract formation or glaucoma. This slide depicts oral manifestations of Crohn's disease, which listed here may include aphthous stomatitis, piostomatitis vegetans, fissures, or oral ulcerations. On the right here, you can see a number of pictures depicting various oral manifestations of Crohn's disease, including fissures, cobblestoning appearance, linear ulceration, mucosal tags, or mucogingivitis. To move on to hematologic manifestations of inflammatory IBD, the risk of thrombotic events among patients with IBD is at least twice those of those in the general population. In two separate meta-analyses, the relative risk for DVT and PE among patients with IBD was 2.2 and 2.85. A separate study looking at over 10,000 patients who had undergone surgery, 1.4% of patients with Crohn's disease and 3.3% of those with ulcerative colitis had a venothrombotic event. The risk of this also increases with flaring disease, and as a result, all patients with IBD who are admitted to the hospital should receive DVT prophylaxis. This does not matter if they are admitted for an IBD flare or for another indication. Bone disease is the most common extraintestinal manifestation and often includes arthritis or arthralgias. It's important to differentiate the difference between these two and also to determine if a patient's symptoms are medication-induced or due to underlying inflammatory disorder. This can often be differentiated by taking an accurate history, as patients who have symptoms or arthralgias that are due to medication will often have worsening of symptoms after receiving the medication, with improvement of symptoms as they get further out from administration of that medication, whereas patients who have arthralgias due to flaring disease will often have improvement in their symptoms after medication administration, and those symptoms may become progressively worse as the medication wears off or as they are due for their next dose. Osteopenia and osteoporosis also may be present and are an extraintestinal manifestation or complication of inflammatory bowel disease. Additional musculoskeletal manifestations include peripheral arthritis, sacroiliitis, and ankylosing spondylitis. There are two types of peripheral arthritis which are depicted in on this slide. Type 1 is asymmetric, often affects fewer than 5 joints, and the joints that are affected tend to be the large joints, the knees, the elbows, the ankles. This is usually acute and self-limiting on the average of a few weeks and often parallels disease activity and is associated with HLA-B27, B35, and DRBO103. Type 2 peripheral arthritis often is symmetric and polyarticular, involving at least 5 joints. It tends to involve the smaller joints, and duration tends to be longer, on average of years as opposed to weeks. This is independent of disease activity and is often associated with HLA-B44. Axial arthritis affects a very small percentage of patients, less than 5%, and does not parallel IBD disease activity. Sacroiliitis is quite common among patients with IBD. It's often asymptomatic, though patients who have symptoms will often present with low back pain or stiffness. They are often found to be HLA-B27 negative. Ankylosing spondylitis may have a classic bamboo spine. The prevalence is about 5 to 7%. Patients will classically present with morning stiffness or back pain. The majority of patients are positive for HLA-B27. This is thought to be unrelated to IBD activity, and treatment may include physical therapy, pain control, NSAIDs, though as we mentioned earlier, NSAIDs should be used with caution among patients with IBD. Other treatment options include sulfasalazine, steroids, and immunosuppression, including anti-TNF medications. Patients with inflammatory bowel disease are at increased risk for osteoporosis. as risk factors for osteoporosis, including steroid treatment, calcium and vitamin D deficiencies, malnutrition, and systemic effects of chronic inflammation, may occur more commonly among patients with inflammatory bowel disease. The GI societies, including the ACG and the AGA, have published screening guidelines for bone disease. They differ slightly, but both of them recommend that postmenopausal women, elderly men, and patients who have received prolonged courses of glucocorticoids, typically longer than a 3-month course, or recurrent courses, should be screened for bone disease. There are a number of dermatologic extraintestinal manifestations. The two that we commonly see and are able to recognize are pyoderma gangrenosum and erythema nodosum. Other extraintestinal manifestations involving the skin include cutaneous Crohn's disease, Sweet syndrome, aphthous dermatitis, and vasculitis. Pyoderma gangrenosum tends to present as painful, tender ulcerations with a blue or violet colored border. It tends to start as a small bump or blister that then grows and develops into a larger sore or ulcer. PG affects up to 5% of patients with ulcerative colitis and is less common in Crohn's disease. There is a slight female predominance. About 50% of patients with pyoderma gangrenosum have IBD. And these lesions often occur at sites of trauma, known as pathergy. And on the body, the lower extremities and peristomal areas are common sites of involvement. This may or may not parallel IBD disease activity, and on the right here you can see examples of pyoderma gangrenosum. There are no definitive guidelines regarding management. Topical or systemic therapies may be prescribed. Topical therapies include local or intralesional corticosteroids or calcineurin inhibitors, and surgical treatment may result in progression of PG due to pathergy, as sites of trauma often are the initiating sites of these lesions. Systemic therapies include corticosteroids, immunomodulators such as cyclosporin or azathioprine, methotrexate, mycophenolate mofetil, anti-tumor necrosis factors, and IVIG in refractory cases or hyperbaric oxygen. With regards to anti-TNF medications, there was a randomized controlled trial, though it was very small, of 30 patients who were randomized to receive either infliximab or placebo. At week 2, 46% of patients on infliximab had improved compared to 6% with placebo, and this was statistically significant. And 20 of 29 patients, or 69%, had beneficial clinical response with infliximab, and the remission rate was 21% at week 6. Cutaneous Crohn's is rare, often presents as granulomatous skin lesions. The most commonly affected areas are the perianal areas. This may not parallel disease activity, and treatment includes steroids and immunosuppression. Depicted here, you can see two photos of metastatic Crohn's disease depicting erythematous papules and plaques, and also ulcers on the skin. Erythema nodosum tends to present as painful, tender red or purple nodules that are often found on the lower extremities, often on the extensor surfaces. It affects about 2 to 7% of patients with IBD. It's more common in Crohn's disease and females compared to males. It is a type 4 sensitivity reaction. It may be associated with certain medications, infections, or other rheumatologic conditions. This tends to parallel IBD disease activity, and no treatment may be required if it is self-limited. It often improves with treatment of GI symptoms or with treatment of inflammatory bowel disease, and anti-TNF, steroids, immunomodulators, which may be used to treat the GI disease and may also effectively treat the dermatologic symptoms. There are a number of medication side effects to be aware of. Anti-TNF agents and immunomodulators may have dermatologic side effects, including the increased risk for malignancy. And patients on anti-TNF medications may develop psoriasis, and if this occurs, then referral to a dermatologist is recommended, as it may be possible to treat the psoriasis while continuing the anti-TNF medication. The development of psoriasis on an anti-TNF medication is thought to be a class effect, so switching the class of medication rather than switching within a class is advised if the psoriasis cannot be managed with topical therapy. To move on to discuss pregnancy and IBD, it is really important to discuss pregnancy with patients who are planning to conceive in the near future, as disease status at conception may affect disease during pregnancy. It's important to discuss the medications that a patient is on, as some of these medications may need to be discontinued prior to conception. And it's often recommended that patients meet with a high-risk obstetrician or a maternal fetal medicine specialist. This is a chart depicting contraception methods and inflammatory bowel disease and special considerations for patients who have IBD interested in contraception. And for the most part, you can see that for most of the types of contraception, there are no restrictions, though I will point out that oral contraceptives may be recommended to be avoided among patients with inflammatory bowel disease if they have prior history of VTE, if they're thought to be high risk for VTE, or if they have active inflammatory bowel disease. With regards to pregnancy and inflammatory bowel disease, this is the chart that I discuss most with my patients in clinic when we are discussing pregnancy. As you can see here, the majority of women who are in remission at the time of conception will remain in remission during their pregnancy, but the opposite is also true in that the majority of women who conceive while they are having active disease will continue to have active disease or worsening disease throughout their pregnancy. And so it's really important that if a patient wants to become pregnant, that you try to achieve remission prior to her attempting conception. Most medications are considered low risk in pregnancy and should be discontinued, and it is important to discuss with your patient which medications they are on and which can be continued during pregnancy. Azicol HD should be stopped, and if a patient is on mesalamine, this can be switched to other mesalamine medications, as all of the others are considered to be low risk. Methotrexate and thalidomide are teratogenic and should be discontinued prior to conception. Methotrexate must be discontinued at least 3 months prior to a woman attempting to conceive. There are multiple studies that have shown no increased risk of abortion, preterm birth, low birth weight, or congenital malformations with biologic use during pregnancy. There are multiple studies looking at birth outcomes among patients who are taking anti-TNF medications during pregnancy. On the left, depicted here, is a study comparing birth outcomes among patients on anti-TNF therapy as compared to controls. And as you can see here, they looked at outcomes including pregnancy complications, completed pregnancies, and then neonatal complications, including low birth weight, death, respiratory distress syndrome, infections, neonatal jaundice, and congenital malformations. And as you can see here, none of the p-values were statistically significant, noting no increased risk of adverse outcomes among the women or the babies who were exposed to anti-TNF therapy during pregnancy. On the right, you can see one meta-analysis that looks at abortions, preterm birth, low birth weight, and congenital malformations among patients who had been prescribed anti-TNFs during pregnancy, and the odds ratio here shows no increased odds of these outcomes among women taking anti-TNF medications. In terms of managing the pregnant patient with IBD, the most important thing is that you do not alter best practices for IBD management due to pregnancy in women with active disease. So for patients who are presenting with diarrhea, you should test for C. diff. You can escalate therapy if indicated and if you think that a woman is having an IBD flare. It may be challenging to determine if a change in somebody's symptoms is due to IBD activity or GI-related symptoms of pregnancy. For example, pregnancy can often result in a change in bowel habits, and this may or may not be due to a change in disease activity. Similarly, many pregnant women develop hemorrhoids, and so the symptom of rectal bleeding may be due to hemorrhoids and may not necessarily reflect worsening activity of inflammatory bowel disease. For most women with inflammatory bowel disease, vaginal delivery is not contraindicated. There are 2 absolute indications for C-section or contraindications for vaginal delivery. These include active perianal disease or the presence of a perirectal, rectovaginal, or perianal fistula. In terms of after delivery, it's important to discuss with patients when to restart their medications, if any medications were held during pregnancy. Most medications can be continued if the mother is planning to breastfeed. There are some medications which should not be started, such as cyclosporin and methotrexate, though these typically are not prescribed during pregnancy, and there are some antibiotics which should not be prescribed if a woman is planning to breastfeed. It's very important to discuss vaccination recommendations for the baby, as fetuses or babies who are exposed to anti-TNF medications, including infliximab or adalimumab, should not be given the rotavirus vaccine within the first year of life, as this is a live vaccination. To move on to preventive care among all patients with IBD, in terms of vaccines, all adult patients with IBD should receive the annual influenza vaccination, and adult patients with IBD who are receiving immunosuppressive therapy should receive the 2 pneumonia vaccinations, Prevnar 13 and Pneumovax 23. Adults over age 50 should consider vaccination against herpes zoster. It is recommended that all patients should be screened for depression and anxiety, as there are higher rates of depression and anxiety among the IBD population. We have previously discussed the screening recommendations for bone density scan and screening for osteoporosis or osteopenia, and smoking cessation should be encouraged among patients with Crohn's disease. There are some special considerations for cancer screening. Women with IBD on immunosuppressive therapy should receive annual cervical cancer screening. This varies from the guidelines for women who are not on immunosuppressive therapy of receiving pap smears or cervical cancer screening every 3 years. In terms of skin cancer, it is recommended that patients with IBD undergo screening for melanoma independent of the use of biologic therapy. However, patients who are on immunomodulators and biologics should undergo screening for melanoma and non-melanoma skin cancers on an annual basis. And we typically recommend that they see a dermatologist every year to have a full body skin exam. In conclusion, up to 40% of patients with IBD may have extraintestinal manifestations. These may include involvement of the eyes, oral mucosa, musculoskeletal system, skin, and/or hematologic system. And extraintestinal manifestations may be treated and may improve by treating the underlying disease, though not all of them parallel disease activity. In terms of pregnancy, it is important to counsel patients prior to conception and review which medications may be continued or which may need to be discontinued and/or stopped prior to pregnancy. Do not alter best practices for managing inflammatory bowel disease because the patient is pregnant. And it's important to discuss the mode of delivery with the patient, obstetrician, and gastroenterologist, and contraindications for vaginal delivery should be considered. Preventive care is essential for all patients of IBD, regardless of whether they are on immunosuppressing medications. This is just a summary slide looking at the relationship between extraintestinal disease manifestations and intestinal activity or disease activity. And as you can see here, and as we discussed, there are some extraintestinal manifestations that parallel the course of IBD and some that do not. So question 1. A 45-year-old male with a history of stricturing ileocolonic Crohn's disease, diagnosed 6 years prior, presents to see you for the first time. He has had multiple complications of his disease and underwent an ileal resection for recurrent small bowel obstruction 2 years ago. He has been on infliximab since his surgery and has done remarkably well. He is currently in clinical remission. He has a history of multiple extraintestinal manifestations, and you discuss that some extraintestinal manifestations parallel disease activity, whereas others do not. Which of the following is independent of disease activity? The answer is C, uveitis, as uveitis typically does not parallel disease activity. All of the others tend to parallel disease activity. Question 2. A 32-year-old female with a history of pan-ulcerative colitis Diagnosed at age 15, presents for follow-up. She was recently married and would like to discuss her options for pregnancy. She is not yet pregnant, but is worried about the effects of her medications on the baby. You review her medications with her. Which of the following is contraindicated during pregnancy? The answer is D, methotrexate, as methotrexate is teratogenic and must be continued at least 3 months prior to conception.